Hello everyone, this is Kirti Agrawal from China T. Georges University. I am a fifth year medical student and today I am going to present you one of the interesting cases I have seen recently. I will present you the whole case in this video along with the lab investigation and the imaging investigations, and in the end we will have a little bit discussion on this particular case and how these certain symptoms were associated and what do we understand from this case. Let's start it.
So let's see the case now. This is a 69 years old female, a non-vegetarian female who came with a complaint of intermittent fever for past 2 months and had fatigue. Fever used to be 39 degrees Celsius and there was no rigor or chills associated with it. Mild headache was seen at the time of fever. No cough, no hemoptysis, no chest pain, palpitations, no diarrhea or gastrointestinal abnormalities, no dysuria, no hematuria. After going to a local clinic, the patient was given IV broad spectrum antibiotic and antipyretics, and the body temperature came back to normal. To know the cause of fever, the patient was referred to our hospital. She was non diabetic, non hypertensive, and no other comorbid conditions was associated. Her family history was non-significant, especially no history of TB was seen or some genetic disorders. Even that was absent. Operative history, recently she didn't had any kind of operations or dental procedures. Menstrual history, she has attained her menopause and there were no postmenopausal dysfunction. We are studying this postmenopausal dysfunction so that we can rule out some bacterial vaginosis or candidiasis, but also the patient didn't tell about any kind of vaginal irritation she might be having or blood from vagina. Drug history, she is recently or she is not on any kind of drugs, and from for head to foot examinations her scalp was normal, eyes appeared normal, no icterus was seen. Icterus we are seeing to rule out jaundice. Jaundice can be like because of some hepatitis, but even that was absent. No gum bleeding was seen. Gum bleeding we can see scurvy or vitamin C deficiency, or there can be some conditions like AML, M4 or M5 that can lead to gum bleeding, but even that was absent. Tongue was normal in appearance. No ecchymosis or purpura was seen that we generally see in cases of thrombocytopenia. Skin was slightly pale and but we couldn't judge from her skin color. No Osler's node was present, like no infective endocarditis, no cyanosis, no clubbing, no lymphadenopathy, no pedal edema, rashes or eschar was seen. On physical examination, being present, the first thing that comes to our mind after listening this is presence of anemia. There can be so many different causes of anemia, different types of anemia like iron deficiency, nutritional anemia, sideroblastic anemias, hemolytic anemias, or there can be some of flow problems or RBC count decrease, something like that. So, after seeing her lab reports, we will be able to understand and figure out what was the cause. Capillary refill was normal. Capillary refill, we saw this because we had to rule out septicemia or sepsis in this patient. Pulse has a normal rate and rhythm. Clear breath sounds and cardiac sounds appeared normal. On abdominal examination was normal. McBurney and Murphy sign were also normal. That is for your appendicitis and cholecystitis. Even that was absent. No ascites was seen. So, yeah, we can rule out some cardiac abnormalities. On central nervous system examination, the patient was consciously oriented with respect to time, place, and person. Her muscle tone was also normal, and power was 5 by 5 in the upper and the lower limbs. Reflexes were normal. Sensory sensations like pain, touch, temperature, and vibration that was also normal. Cardiac sounds, ECG was normal and echo showed some mild aortic reflux and valves were completely normal. So even infective endocarditis was ruled out in this patient. Vitals, the temperature was 39 degrees Celsius, and after giving IV antibiotics, it was 36.6 degrees Celsius. Pulse rate was 61 per minute, her heart rate was 72 beats per minute, and blood pressure was 89 by 69. She was quite hypotensive. After looking at the history, what are the important things that we note? The fever was present for 2 months, which came back after giving IV antibiotics. Pallor was still present. She was still having fatigueness, and blood pressure was low and mild headache at the time of fever. Even when she was there in the hospital, she had mild headaches.
As fever was one of the most important symptom this patient had, let's see how is fever being generated in a person or in a patient. Let's take, there are so many different causes of fever. Let's take example of infection. That is your exogenous pyogen that is going to enter into your body and release some endogenous pyogens. These endogenous pyogens are your interleukin 1, interleukin 6 and TNF alpha. So yes, in cases of fever, interleukin 1 is the interleukin which is increased. After these cytokines have increased, they go into from our blood, it reaches to our CSF, and from there it is going to trigger the OVLT centers. What is the OVLT? Organum vasculosum of lamina terminalis, which leads to the release of serotonins and substance P. After these substances are being released, it is going to trigger the thermoregulatory neurons that is present in the preoptic area of our hypothalamus. Yes, this is the preoptic area where there are thermoregulatory neurons. So these thermoregulatory neurons, and of course the preoptic area is having basically two major functions, that is sleep regulation and the second is temperature regulation. After these thermoregulatory neurons are being triggered, the body temperature from 36 it will increase and it will go to like 37, or let's take 38 or 39 degrees Celsius. After it has reached to 39 degrees Celsius, the body will think that 36 was our normal range, but now 36 is not our temperature, it's 39 that we have to maintain. So what does the body do? It leads to vasoconstriction all over our body, leading to chills and also some shivering. This leads to increase in the body temperature, and hence the lower body temperature and the temperature that is maintained by hypothalamus is in coordination. So after this 39 degrees Celsius, it leads to increase in body temperature and hence this leads to fever. In this patient also there might be some reason which has led to this increase in fever. So let's see what are the causes of fever. The most common cause of fever is of course infections. Infections like bacterial infections, viral infections or fungal infections. For fungal infections, it's easy to rule out because there will be some scaly lesions and the patient will be presenting with some itching. While in case of bacterial and viral infections, clinically we can ask the patient about her history. Like for viral infections, generally as the virus doesn't survive outside in the environment, it is generally being transmitted from person to person. So in the family, there might be some mother or father who is having some kind of infection, and then the child also present with that. So we can think about viral infections. What about the bacterial infections? To rule out that, we can see her CBC reports and we can see the increase in neutrophil levels. But in viral infection, there is increase in the lymphocytic levels. So in this patient, we have done CBC, KFT, LFT to rule out all the kind of infection if she was having, and even blood smears were done to rule out bacteremia. The second most common cause is, of course, cancers. Leukemias and lymphomas are generally presenting with fever. Lymphomas, as classical Hodgkin's lymphoma, we can see the Pearl-Epstein fever, which comes and goes for 7 to 10 days. Even that was absent in this patient. So even we can rule out that. So for ruling out leukemias, we did some bone marrow examinations. There can be other causes like rheumatic causes or rheumatic disorders like polyarthritis nodosa or Takayasu arthritis, or there can be rheumatic disorders. So for that we did ANCA and ASO titers to know if she is having some of the rheumatic diseases. The next common cause is endocrine disorders, like if she might be having hyperthyroidism or something. After that, we also have some tumor or trauma conditions in which, like, complete link between your hypothalamus and the body is broken down, so there is no regulation of body temperature even at that time. But tumor and trauma in this patient, we couldn't see that. Even after blood transfusion, we can see some fever conditions, but in blood transfusion it's generally because of ABO mismatch. In this patient, she didn't had any kind of blood transfusion recently. Her CBC and her lab reports to see what was exact cause.
CBC report showed that her WBC counts were decreased, leukopenia was present, even like neutrophil level, lymphocytes level, and eosinophil levels, all the three were decreased. RBCs were decreased, some anemia is present, of course, even the hematocrit and hemoglobin level were low. Platelet were normal, so we can see that pancytopenia is not present in this patient. What about the MCV values? MCV is generally like 80 to 100 femtoliters, but in this patient there was increased, that is 106 femtoliters. So there are so many causes for megalocytes, like liver disease, hypothyroidism, megaloblastic anemia, of course, and cytotoxic drugs. So later we will see what was the main cause. Blood culture was normal, so there were no kind of infection which was going on. See the inflammatory markers, ESR was increased, CRP was increased, interleukin were increased, that is interleukin 6 was significantly increased. So from here we can understand that the fever might be because of some kind of inflammation or proliferation of cells that is going on in her body. And as the fever was there for 2 months, then yeah, definitely inflammation is there, and it has been quite long that the inflammation is going on. ST was in normal range, ALT was normal, total proteins were also like normal, ALB, that is your albumin, even that was normal, creatinine kinase was 10. We can, yeah, creatinine kinase is because of some kidney disorders. We generally see that as a marker, but creatinine kinase is basically because of the muscle mass in the body. So, hence, creatinine kinase is having two different values. For males, it is 5 to 100 international units per liter, while in females, it's 10 to 70 international units per liter. LDL was decreased in this patient. After seeing the electrolytes, the chloride level was normal, calcium was decreased, and iron was decreased, and TIBC was decreased. So from here, what do you think? Like iron is decreased, okay, we can think of iron deficiency anemia, but TIBC in iron deficiency anemia is increased. TIBC is total iron binding capacity, right? So basically, it is the iron receptors which are trying to grasp more and more of iron at the time of iron deficiency anemia. So in that case, the TIBC increases, but here the TIBC was decreased. So there is some, we can generally these two are decreased in case of anemia of chronic disorders. So let's see like what is the reason she is having, what is the chronic disorder she is having. In case of anemia of chronic disorder, as everyone knows, we have to treat the cause of anemia. That the means the chronic disorder should be treated. So let's see. Urine examination and stool examination. Her stool examination was completely normal, and on urine examination there were presence of leukocytes, that there were some WBCs present in her urine, and epithelial cells were also present. So from here we can think that yeah, there can be some urinary tract infections, but as the patient did not say anything about this, or maybe she felt that it is quite normal to have abnormalities in her urine. So, to rule out rheumatic and tuberculosis, we did her ANCA, and ANCA was negative. T spot was non reactive. On imaging investigations, echo, mild aortic reflux was seen, and that is quite common to have it. An older patient. USG was normal, so no hepatosplenomegaly was seen, or no other abnormalities were seen. CT scan, her brain CT showed multiple lacunar infracts in frontal and temporal lobe. So from here we can see that she was having headache at the time of fever. So we can think that headache might be because of the lacunar infracts that is present. On chest CT, fibrous or exudative lesion was seen in her lower lobe of lung, but the patient did not tell about any of these difficulties in breathing or something. Even on auscultation, this was not quite significantly noted. Lymph nodes were normal. PET-CT showed a diffused increased bone marrow metabolism. So there is some kind of hyperplasia or increased proliferation in her bone marrow which is going on. This might have led to increase in inflammatory markers and hence can be cause of fever. Mild spleen enlargement was noted. Left knee arthritis and a few fluid accumulation in her left knees was seen. But when I asked the patient that is she able to walk or she having some kind of abnormalities in her joint or joint pain, she just said that she is not having anything. Cerebral atrophy was seen. Of course, she is an old patient, so that is okay. And lacunar infracts. Fibrous proliferation in the lung and right renal cyst was present. This renal cyst would have led to have some WBCs increased in her urine and also epithelial cells. After looking at the diffused increase in her bone marrow metabolism, her peripheral smear and bone marrow examinations were done. This showed an hyperplasia of bone marrow. Granulocyte system accounted for 51.5%, which showed some leftward shifting and increase in neutrophils. Proportions of RBCs were 38%, with increase in middle and late RBCs as a main type. Some middle and late RBCs had an increase in volume with visible mitotic phases and uneven sizes of mature RBCs, and megaloblastic transformation were seen. Hence, we could like think of as the patient was having anemia, this patient was having megaloblastic transformation, so we can drive to some conclusions of megaloblastic anemia. But for ensuring it, we need peripheral smears and of course the level of vitamin B12 and folate as well. Megakaryocytes were normal, that is, your platelets were completely normal. No parasites were found, and lymphocytes were relatively reduced, and morphology was completely normal. Peripheral blood smear showed an increased lymphocyte proportion and uneven size of RBCs, that is, your anisocytosis. Platelet was scattered and distributed in a small cluster. Hypersegmented neutrophils was seen, and no malarial parasite was seen. Her vitamin B12 levels were decreased, her folate levels were decreased, and homocysteine levels were increased. So, we see that vitamin B12 acts on certain reactions in our body, that is your thymine synthesis, homocysteine to methionine, and methylmalonyl coenzyme A to succinyl coenzyme A. If any of these pathways or reactions are being disturbed, then we can see that there was some vitamin B12 deficiency. So we did homocysteine levels and that was increased in this patient.
So, after listening to this case, what do you feel? So, let's discuss together. This is a rare case of pyrexia associated with megaloblastic anemia. How are these two conditions linked to each other? Let's discuss on this. In this particular case, I should say, and also some of the studies say that infection is the most common cause of pyrexia being associated with megaloblastic anemia, and in 73% of the cases it is resolved after giving IV antibiotics, but still the patient might be showing symptoms of fatigueness and all, and hence the patient might reach to us. So in these kind of patients of megaloblastic anemia, it is because of the decrease in the level of neutrophils and macrophages, which is leading to making them more susceptible to infection. So in this particular patient also we saw this, that the infection was there because of her decrease in her neutrophils and macrophages. Also in the CBC I have mentioned that the patient was having neutropenia. What do you think is the cause of fever if it's not associated with infection? And there are certain conditions in which megaloblastic anemia is associated with fever, but that is not due to infection. Yeah, there were some studies which were done, and there were some theories which were postulated that may be because of a decrease in oxygen to the hypothalamic center, or our thermoregulatory center in the hypothalamus, which is leading to fever in these kind of patients. The second theory just said that there might be some defects in the thermoregulatory center, which is leading to a rise in the body temperature. Third theory said that because of the hyperproliferation of the bone marrow, it can be the increase in the release of inflammatory markers, which would have led to systemic fever in the patients. In these kind of patients, it is generally after getting a correct diagnosis like vitamin B12 deficiency, megaloblastic anemia, we give them vitamin B12 and folate to recover from it. And these patients are quite easily recovered and have a good prognosis. Also, there is some message from these kind of cases that we should understand, that pyrexia of unknown origin can also have megaloblastic anemia as one of its causes. So, if a patient comes with pyrexia of unknown origin, we should also check in the level of vitamin B12 and folate, and also we should do some peripheral blood smears to check in if the patient is having megaloblastic anemia or not. Thank you everyone for watching this video, and I just hope everyone liked this video and everyone has learned something from this video. Please give in a thumbs up if you like this particular video. In the next case and the next video, that is also really very interesting, and stay tuned. Thank you. Bye bye.